Welcome to the DaVinci Hour podcast. I'm your host, Dr. Maxwell Cooper, and in this podcast series, I interview physicians, medical innovators, and entrepreneurs making an impact on healthcare. This podcast is produced by DaVinci Academy, a multimedia medical education company that provides podcasts, video courses, and digital textbooks. You can see more on our website, www.dviacademy.com, and our YouTube channel, youtube.com/c/DaVinci Academy Med. This podcast is sponsored by Doc2Doc, the personal lending platform designed for doctors by doctors. Do you have some big expenses in the near future? Maybe you're moving, applying to residency or fellowship, fixing up your car or home, or starting a new practice. Doc2Doc believes that traditional lenders overestimate the risk of lending money to doctors, residents, and medical students, focusing too much on the challenges of their financial past and giving them insufficient credit for the promise of their financial future. Check out Doc2Doc's personal loan options at doc2doclending.com/DaVinci. Hey everybody, welcome back to the DaVinci Hour podcast. I'm honored to be joined this week by Dr. Brian Cole, who's the Associate Chairman at Rush University Medical Center for the Department of Orthopaedic Surgery, and then he's also the Managing Partner of Midwest Orthopaedics at Rush. So Dr. Cole, thanks for joining us. Really appreciate it.
I'm happy to be here. Thank you.
Great. So maybe give us a little bit of background, just briefly, like where you went to school, where you did your training, and then what your main clinical practice focus is on right now.
Sure. So I'm about 25 years in practice. I'm at Rush University Medical Center. The formal name of our group is Midwest Orthopaedics at Rush. I trained at the University of Chicago, where I got my MD and my MBA sort of simultaneously, and then went to the hospital for special surgery for residency. I did a year of general surgery before that, like most of us who go into surgery, and did a year of research in metabolic bone disease while at HSS, and then finish up with my fellowship at the University of Pittsburgh with Freddie Fu, Chris Harner, and JP Warner in 97. So I've been in Chicago ever since, and have enjoyed a really wonderful practice in sports medicine, as well as a private sort of academic environment with a very terrific group, multi-specialty group in Chicago.
Awesome. Thanks for giving us that overview. I think for the listeners who may be a little bit unaware of, your practice, and maybe just to also, those who are aware so they can learn a little bit more, maybe tell us about the logistics of, how your guys' practices work up. It sounds like it's a physician-run private practice, but you also serve as an academic department at Rush University. Maybe give us a little bit of background how that works.
So Rush University Medical Center is a non-for-profit classic hospital situation where they have multiple departments. And we're the Department of Orthopaedics and pretty much embody virtually all orthopedic surgeons on staff at Rush. But we are a group that's about 35 years old that has always been a private independent practice with a very symbiotic relationship with an academic medical center. So while the practice of medicine is somewhat separate and distinct, we share contracts. There's the ACGME residency and fellowship programs, research, philanthropy, some branding are things that we do together, in addition to taking care of sports franchises and co-marketing agreements that we might have as well in that area. So I think, we're fortunate that we've been allowed to function in a very independent way, but sort of find the best parts of each organization to see where we could have really good synergies. It's not without challenges. The hospital situation is becoming increasingly challenging as things sort of migrate to the ambulatory care setting, where in ASCs or ambulatory surgical centers, that's different than what goes on in the hospital for inpatient facilities and so facility fees. So, many hospitals are finding themselves in significant challenges related to human resources, maintaining nursing and anesthesia, and maintaining the viability and the schedules of the operating room. And in addition to, sort of typical service lines that they have to be responsible to. So we've been able to remain nimble, but sort of interdependent on one another for various aspects. And, we each have our own respective challenges, and we try to find areas that we can partner together. So none of these relationships are always perfect, but I think we do as well as anyone in the country in maintaining a sort of a synergy and a symbiotic relationship for clinical practice.
That's awesome. I'm curious, are you guys the only department that are set up like this at Rush, or is this something that's common at Rush? Are there other departments set up like
Yeah, it's a
this?
great question. So anesthesia for some time was, yeah, I think it actually still is considered an independent. They call it Rush Anesthesia or Rush University Anesthesia, but it is an independent private group. So, but most every other service line is a full service line that is within the walls of Rush in terms of how they contract and what their obligations are to the hospital. So it's not a common model, and it does pose challenges when we sort of have to deal with our own business lines and we don't always see eye to eye, and our missions may be different. So it's not without challenge, but we have made it work for a long time, and we through a lot of discussion and transparency, we can navigate these things, I think, with very little difficulty.
That's interesting. It's interesting you bring up ambulatory surgery centers. I'm curious, does your practice own some of those independently of Rush University, or are those through the university health system as well?
So, our first ambulatory surgery center was a joint venture with Rush on campus. That's probably 35 years old, and that was at a time where we really didn't have a good understanding of the ASC environment. We weren't doing arthroplasty and spine in an outpatient setting, and there were only a few clinicians that were doing outpatient cases such as sports, hand, and foot and ankle, and that was pretty much it for a long time. However, over the last 15 years, there's because one, reimbursement allows the opportunity to do outpatient spine, outpatient joints, and two, people are becoming more comfortable in facile. We independently have gone out and developed our own ASC initiative. So we now have 7 ASCs that are in part owned by individuals and or the group Midwest Orthopaedics. And we do still partner with some with Rush, and many of them we just simply do on our own, perhaps with the collaboration with the management company to some lesser or greater extent.
Interesting. I'm curious during these times where you hear about these healthcare systems, both private and academic, buying up hospitals and buying up ASCs and things like that. I think what do you feel like your practice has done well to kind of still remain, an independent group without having to be, essentially gobbled up by some of these other, larger systems, if you will?
As we look for sustainability, there's either a defensive strategy to maintain the status quo, and then there are offensive strategies which involve real growth. And keep in mind that growth can be defensive as well. So in the Chicagoland area, we've been faced with a lot of consolidation. So there are important benefits that come from size, not just scale, but the ability to negotiate and have a dialogue with payers is very critical. To have enough of a geographic swatch of coverage that you can be relevant to a payer in terms of providing access to their clients, to patients. It allows us to negotiate at the ASC level for contract rates and so forth. So and then there's economies of scale that happen with size. It has become so almost irrationally costly to run a practice. If you look at what it takes to get out of the gates, there's a fixed cost that's required that relates to physical plant, insurance, malpractice, technology, IT. The entire infrastructure to run a practice is large, whether or not you have 5 or 30 individuals. So because there's this sort of known fixed cost that isn't even particularly marginal, you realize that you have to have a certain size to absorb from an overhead perspective to really make a go at it. So the way we've done it is we've always had organic growth where we grow responsibly with fellowship trained surgeons and non-surgeons. We have 100 providers, about 50 advanced practitioners, and 50 physicians, about 35 to 40 of whom are surgeons, but we have non-surgeons, physiatry, primary care, sports, a chiropractor, and that sort of complements the surgeons themselves. We're about 800 employees now, and we have 17 physical therapy centers, 7 offices, 7 ASCs. Every facility has MRI or advanced imaging and so forth. So in order to, remain, to have a sustainable business model as an independent practice, you can't really do it on professional revenues alone. In other words, seeing patients and even having reimbursement that comes from doing surgery is barely enough to keep the lights on given the cost of practice. So it really requires having an integrated system where we participate in all aspects of care related. Could be perioperative education, it could be nutrition, it could be bracing and DME, and it obviously involves having access to ASCs whereby we have ownership, as well as physical therapy. So it's nearly impossible now to maintain independence financially without having verticals as part of your practice. It just doesn't work. The economics don't work. We're in the one profession where the cost of doing business continues to go up every single year, and the revenue side stays the same or goes down. The margins every year for private practice continue to get slimmer and slimmer. And what we experience is honestly no different than the hospitals. They have different forces. Hospitals are facing the same, post-COVID, facing the same headwinds, if you will. And even more so if they were not prepared for the exodus to the ambulatory surgery center environment, though they have trouble maintaining their margins just because the sheer volume of things that go through the hospital system to keep it sustained has been decreasing exponentially in various health systems.
That's really interesting. So I mean, building those vertical service lines like you talked about, giving a comprehensive care of the patient. It's interesting that, I imagine as managing partner, you're probably as much a doctor as you are a businessman. I know you mentioned earlier, you said you got your MBA while you're in medical school. I'm curious, how have you picked up kind of that business acumen as you've gone along? Is that something you've picked up along or done some extra like education or training for?
Yeah, I think, I did my business school during medical school because I was accustomed to being a student. So it was a good time from that perspective, and economically it worked because of, scholarship and so forth. But from a knowledge point of view, it's probably not the best time to do it. And because I really had no idea how I would use it. And I didn't really know what to focus on. So I did a general MBA in health administration. So while the principles were very useful and I learned a lot at University of Chicago, I would say that it's really been learning along the way. And it's everything from contracts to organizations, leadership, understanding the payer landscape, reimbursement, coding, medical liability, contract liability. I mean, there's just any number of things that go on that are related to business. I still love seeing patients. I mean, my days, a typical Monday when we're, taping this episode would be, I'll start at first meeting at 6:30 in the morning. That's a business meeting, another 1 hour meeting from 7 to 8, another one from 8 to 8:30. And then I'll see 65, 70 patients. And then when the day is over, teach a resident conference and then have perhaps another couple of calls and follow up with with athletes that, may have been injured or there's ongoing activities and answering phone calls. And that can go till 8 or 9 o'clock at night. And that's a very typical Monday. The business side of it is something that occurs throughout the day. And, our best place probably is still, seeing patients and doing the day, doing what we do best, but having clinicians involved in the day-to-day decision-making, in addition to having a C-level, the CEO, CFO, and so forth, is a good balance, because I think having one or the other, but not both, can be particularly challenging. So I don't think a physician's best place, if he is interested in clinical practice, is to be the CEO of a practice, but to be managing partner and work collaboratively with an executive team of other physicians as well as your C-level people. I think that's a good recipe, at least it is for us, to maintain a sense of sustainability.
Oh, that's interesting. So you essentially have like a physician, the partner is a governing body, if you will, and then you have a non-clinical, executive team as well. I think that's really
exactly
interesting.
Right.
Okay.
Yeah, that's exactly right.
Interesting. I guess the other thing I'm curious about is, I know you guys are a high volume, practice, but you also have, excellent, residency and fellowship programs as well. Do a lot of orthopedic research as well, publish a lot of manuscripts, present at conferences. How are you able to, I guess, balance that being, having high clinical volume, but also having, excellent academics? Because, many people will, I'm sure you've heard at certain points, some people say, well, you can't be a high volume clinician if you're, a really good researcher or productive researcher, and vice versa. I'm curious what your thoughts are on that. And
yeah, I mean, I think, again, this is a situation where you really need to surround yourself by the right people. If you want to be good, good is not so hard, but to be great, you really have to have the right people around you that are able to function independently, but also collaboratively as a team that can put their egos aside, and that their day job is, an independent private practice. There's really no, and we do compensate through a point system, academic productivity, but virtually every one of my partners who's fellowship trained, who are also fellowship trained, participates in some degree of research. So, I'll give you an example in the section of sports where we have, I think, 9 attendings and then about 5 or 6 primary care sports. We meet every Monday night collaboratively. Each of us has 2 or 3 research coordinators. We raise money through philanthropy to help support these coordinators who are often, looking to get through medical school, for example. They'll take a year to improve their competitiveness for orthopedic residency, or even a pre-med student. And we meet, tonight we did cartilage basic science. Last week we did clinical trials shoulder, for example. And we have so much going on that we have to divide it up into basic science and clinical and by joint. So it could be shoulder, elbow, knee, and that could be clinical and basic science. So within section of sports medicine. But I think that the fact is we have people that are very motivated. They're willing to spend the time writing and reviewing papers and being timely. They're willing to collect outcomes. We use patient IQ to collect outcomes, so we can basically in a very short amount of time identify a topic we've prospectively collected data, and we can assign someone to it. And so, I think I had 58 publications last year in 2021, and it's not because I did all this research myself. It's because we have a team of individuals who collaborate really well together. So it could be me and any number of my partners who also are interested in research and are willing to spend the time doing it. So while all of us are interested in being clinically busy, night times besides family and exercise and whatever else we do, it's not hard to spend the time reviewing abstracts, papers, and things of that nature that, those who are a little bit younger than us are sort of helping to keep things on the rails. And that's really, again, just goes down to surrounding yourself with people who are really excellent and have the discipline and the independence to actually deliver. So it's all doable, but it really gets down to who you have around you. I'm sure people who can function like that, and we go through great efforts to intentionally bring these types of people in and who are interested in taking care of people, who are ethical, who are well trained, but at the same time have an interest in also performing research and knowing that they're not going to have a carve out to be paid for that time. So I think those things are getting more challenging. But I think if you truly want to be in a private academic model, you have to be willing to work hard. And then your sort of academic philanthropy is spent doing research and mentoring younger people and surrounding yourself by people who are at least as good, if not better than you are.
I think that's a really interesting point, building, a strong team around you that can, support you in many different facets. I'm curious from your standpoint, are there any surgeons, you kind of touched on, surgeons that would be a good fit for your practice model? Is there anyone who I guess you would say maybe would not be a good fit or maybe should consider, other types of practice models? Because I imagine although what you've built is great, it's maybe not the best fit for everybody.
It's not for everyone. Yeah, it's not for everyone because we have a large infrastructure. Our overhead is quite significant. And if someone is, in a hospital setting, the incentives are a bit different. A hospital employed physician is often they may be on an RVU base, but they may be on a guarantee, and the incentives are far less and much different. When you're in a true private practice model, you're exposed to all the overhead as an equity partner. So in order to, make it work, people have to be very like-minded and all kind of rowing in the same direction. So I think if someone is looking for more of a stereotypically 9-to-5 type environment that is really happy to be a clinician, doesn't want to be burdened by the administrative aspects of practice, everything's kind of done for them, and they just like showing up, seeing patients, getting people on the surgical schedule, having consolidated aspects of the practice, such as scheduling and pre-certification and all the things involved with running a practice, that's all consolidated in one location, then that person's much better for sort of an academic environment, or a hospital environment, not necessarily academic. There are then hospital academic jobs, which are maybe a step above that, where, part of it is the expectation that you'll be performing research. But, these are the clinicians that I'm surrounded by are often very like-minded. They want to develop a good reputation and maintain their reputation. They're willing to go out and meet people, to lecture, to go, to lecture to potential patient groups, to work with a physical therapist, with referring people and so forth, whether it's workers' compensation or it's, schools and sports, what have you. And at the same time, they keep up to date. They're interested in leadership positions in specialty societies and so forth. And they're interested in publishing. That is not for everyone. But, if you choose that path and you're right for that path, then, you'll have intellectually and emotionally, I think, a very stimulating, satisfying career in that area. I mean, we provide an infrastructure that works really well for people who are motivated in that way. But as you intimated, it's not going to be for everyone.
That's interesting. I'm curious, segueing a little bit, we've mentioned, you're the head team physician for the Chicago Bulls and the Chicago White Sox. And I'm just curious how you got into doing that. And then, what your advice is for, younger physicians looking to get involved in, professional sports as well.
Well, most professional sports organizations will require being certified, CAQ certified in sports medicine. So it requires an individual to have a sports medicine fellowship to get out of the gates. So assuming that's the training they have, then they can either participate in team coverage, either as a orthopedic surgeon with a specialty in sports medicine or primary care sports medicine. They both are pathways to get there. One is surgical and obviously medical. The other one is just medical, but there's a lot of overlap. And the other thing that's kind of required is it's very difficult as an individual, not part of a healthcare system, to provide all of the necessary aspects of, what it takes to manage an organization. So another great benefit of having Rush is that, a lot of things I deal with have nothing to do with orthopedics. It can be dermatology. It could be OBGYN for, significant others. It could be pediatrics. It could be dermatology and so forth. So we need access to an entire health system because that's just like anyone else. They have non-orthopedic, non-sport related problems as well. But it also requires issues, dealing with exercise physiology, kinesiology, physical therapy, rehabilitative medicine. I mean, there really is a whole plethora of specialties that go into helping manage a team, but there often is one quarterback who does it. So for us, what I think a lot of the organizations in the Chicagoland area recognized early on is that it's difficult. They had one excellent physician who was helping manage the entire enterprise, but it just isn't enough for one person to do it. It really requires an army and it requires people in different specialties. So most sports organizations, NFL, MLS, and NHL, MLS, NFL, NBA, MLB, independent baseball, colleges, dance troupes such as Joffrey Ballet and so forth, they really want a health system with one person championing or quarterbacking it. So I think it first starts being in the right system before you can really potentially go out and sort of see if there's a proper arrangement to be had as a team physician.
I guess kind of going off that, I know you have your own podcast as well that you've been doing for some time now. Maybe tell us a little bit about that. I'm curious what your focus
Sure.
is and who your main audience is.
Yeah. So Sports Medicine Weekly is our podcast, and it's available on any, podcast outlet that your listeners probably find your podcast as well. And we used to be on ESPN radio for about 8 years, and then we switched over to the Score for 2 years, which is a regional presence. And we just realized that radio was not a good fit for what we did. It was very inefficient. Radio has had, challenges as far as sponsorship and buying radio time and so forth. So we elected to go out on our own, and having a podcast provides, obviously the ability to get the messaging out there, leveraging your partnerships. We raise money for supporting orthopedic research. It's a non-for-profit organization. So my goal initially was to just provide education and really to lay people on everything from nutrition, injury prevention, recovery, novel therapeutics, biologics, regenerative medicine. I mean, anything that I think is out there that people have interest in, we can do a topic on. What's the healthiest alcohol to drink? Why, what's a diet fad? Tell me about intermittent fasting. Are carbohydrates really bad? What about the supplement space? What about anabolic steroids? What are the downsides? We have professional athletes on. We cover a variety of topics, anything from gambling and sports medicine, gambling and sports to, how to keep your, 14-year-old from developing an ulnar ligament or a little leaguer's elbow. So it just provides a platform that's not particularly arduous, that allows me to educate more than just one patient at a time. And that was really the premise. My one of my missions and interests is really in educating people. I feel like I'm an educator every single day in the office for patients, and to provide a place that I could have content developed that was very concise, compartmentalized, authoritative, evidence-based, that people would find useful on virtually any topic. And I don't even know, where we could be over 600-700 podcasts at this point, so that's what we do. And we have sponsors, maybe like you do, that are we leverage their relationships. We do things that are very consistent with their own sort of business mission, and we find people that we can collaborate well with for topics and so forth. So so it's Sports Medicine Weekly, and certainly we'd be more than happy to feature this in any of your other episodes and link to you if that's something you'd be interested in doing.
Yeah, absolutely. And we'll definitely put, where we, the description and the links for your podcast in the show notes so people can find it. And
Great.
Definitely appreciate that. My last question for you is, you're this very busy, physician, researcher, educator, podcaster. What do you do outside of all that to kind of balance your life, if you can find that balance?
I feel like, I give more talks on balance and leadership than I do anything else these days. But, for me, I have some passions. I like to ski. For many years, I was climbing one mountain a year. So that's what would keep me fit, and probably get back to that. I haven't done that in a couple of years. And I like to sail and even race sailboats. And I have 3 kids. So, and they're college or just after college age, well, 23, 21, and 17. So that's, I don't like to miss anything that they do. And that's something I've placed a premium on. So, and, we like to travel and so forth. So I stopped working Fridays, seeing patients and doing surgery many years ago. So spend time at, in the summers at, lake home on Fridays, and I may take calls and do conferences and things like that, but I don't do any patient care on those days. So that's held my schedule quite a bit. So it's a lot, but I, to your point, I think achieving balance, and if people want to sort of learn more about, some of these techniques, and not just that I've thought of, these are things that I've learned from a number of my mentors. My website, I've done TED Talks and other, educational forums that, sort of talk about this exact issue. My website's briancolemd.com, not too complicated. So if people are interested, there's a couple of, YouTube videos and so forth there's one's a TEDx talk, and there's some other ones. I did one last year in Switzerland talking about, the epiphanies of a busy surgeon. Those are things I like to talk about because I think if I keep it first to mind and I stay fresh with that, it keeps me on task, because it's very easy to get out of balance if you don't contemplate all the different responsibilities you have and sort of keeping those in check, especially if you have a family.
That's interesting. It sounds like, even though you're busy, you find the time and make the priority and, make things work, which is really interesting. I'm curious, do you do your sailing on Lake Michigan there in Chicago, or is there somewhere else you go for that? Oh, that's pretty cool.
We have Lake Michigan's an amazing lake for sailing, but it can also be pretty treacherous. We have seen overnight races, local races, but we also in Indiana, where we have a lake home, has a number of really wonderful inland lakes. So that's a lot of recreational sailing, and I'll do some regattas with some on sea scows and smaller boats as a crew. But we have a lot of sailing in the Midwest.
That's awesome. Well, Dr. Cole, really appreciate you coming on and taking time out of your really busy schedule. You mentioned your website. Is there anything, any other platforms you're active on that you'd like the listeners where they can follow you and reach out and things like that?
Sure. I have, they can follow me at Instagram at Brian J. Cole, MD. So we do a lot of educational content there. Obviously we're on Facebook and do a little bit of Twitter. And then, but I think the Sports Medicine Weekly and my website, Brian Cole, MD, is a really great resource and links to everything. I mean, for me, it's all been about education. I'm plenty busy clinically as a, sports medicine. I basically do shoulder, elbow, knee, and cartilage restoration has been my area of expertise over the last 25 years. But I've really enjoyed being sort of in the moment, having the opportunity to teach and to mentor. And that's, I'd say, the last phase of my career is going to spend a lot more time mentoring younger people to help provide opportunities for them, just like people did for me as I sort of went through my career and in its development.
That's awesome. Well, Dr. Cole, thank you again for taking time out of your schedule. I really enjoyed talking with you, and I think the listeners will learn a lot from this episode for sure.
Thank you, and I appreciate you having me, and best of luck with your show.
Thank you for listening to this episode of the DaVinci Hour podcast, presented by DaVinci Academy. Please be sure to subscribe to our YouTube channel and follow the podcast on your podcast platform of choice to catch the latest episodes. Please leave a comment or a review and share it with a friend. Lastly, you can find all of our podcasts, video courses, and books on our website, dviacademy.com. Thank you for listening.